Okay, so let's invite our panelists up. I do have an audience participation question that we were going to run first, just to give you an idea. Just curious what everybody thinks about this. If a blood test suggests cancer, but the cancer does not manifest for several years, is this a marker of risk or a marker of diagnosis? Okay, good. I think this kind of proves the point. Absolutely. That's just what I want. And actually, I'm not going to say that the answer for sure on this case, because in fact, with blood tests, it does get a little bit more complicated, especially with the early signals, because there actually is a little bit of overlap there. But you can see that this whole concept, and in imaging, well, it's bad in imaging and it's bad with blood markers, because I've seen blood tests that clearly are diagnostic tests, but they're just repurposed as risk predictors, because they get some signal and years later. And in lung cancer, we see the same thing. I think I wanted to start this off with a simple question. Rowena actually brought it up, and this is to the panel. The Brock model, as she brought up, the Brock model describes itself as you read their own description, they describe themselves as predicting lung cancer within 2 to 4 years when it shows a nodule. What do you think of that statement? Does it predict lung cancer within 2 to 4 years? Is that what the Brock model does? This is their own description. I'm not making it up.
Well, the AUC is not great, so that's for starters, right? So it's not a wonderful, sure thing. And we've talked about this before. To what extent a risk calculator is static as opposed to an image over time that changes, and is it diagnosing or predicting? And arguably, the risk calculators are static, except for maybe age, those that incorporate age, for example.
Dr. Kazerooni, do you have any thoughts about this?
I think it is a prediction of future risk. But I think one of the things you're trying to get at is that imaging is a combination of risk and diagnosis, and it's hard to separate the two.
I agree with that. I think in practically, there's risk for a population which might have a certain appearance, and there's risk for a patient that you're seeing. And we're concerned about an individual generally more than the population. So the recommendations are a little bit challenging. What do you say to somebody? Well, somebody with this appearance, the chances are it's malignant or it's not malignant. They want to know an answer. And so what do we recommend then? I'm really challenged with this. I'm challenged with this also with the calcium scoring.
You don't have to add any more comments if you don't want. If you.
Oh, you don't want to hear what I have to say?
Not everybody. No, not everybody has to say something. I'm just offering you if this is something you want to comment.
Well, okay. Here's my perspective on this. So, not being a clinician, but to me, there's uncertainty, right, in any measurement, right? So, I'm trained as a scientist. So, and I think what you're talking about, at least from my perspective, in terms of risk, is a sense of the uncertainty, right? And you make a call eventually based on a level of certainty and you call it a diagnosis, but there's always that variability underneath that decision.
Well, I partially agree with him, but I think it's kind of a diagnosis, because if I remember correctly, in the Brock model, they do consider not only the patient characteristics, but also the nodule size, location, and some speculation status. So it means they found something, then according to the definition that Dr. Yip just mentioned, I think then it should be diagnosis.
Well, I think for all of these models, and also like for blood tests, but also for the Brock model, in the end, even for us professionals, it's very difficult to work with probabilities. And a patient wants to know his diagnosis: do I have cancer or don't I have cancer? And even for us, what we need is more like strict guidelines and cutoffs. So this is for all these kind of models. From what probability or from what cutoff should I act and should I pursue? And that is with a lot of models currently published. They published very nice AUC. I think Rowena showed very nicely that a high area under the curve doesn't always correspond with a perfectly working model. But these AUCs alone doesn't help us as clinicians. So what we need are guidelines and knowing when to act.
Okay, so I don't claim to be the oracle of truth, but what I would say, and I think this is really important, the Brock model is a nodule is in front of you. You're not worried about future with that. You're worried, is this nodule malignant now, yes or no? Because is it a disease? To me, this is strictly a diagnostic problem. Probability of malignancy in a nodule that's right there, that's the only concern. You're not worried that the nodule is benign and may in the future turn into malignancy. You're worried right now. But this, to me, is a wonderful example of what kind of the challenge is. And especially because it takes time. You have a small nodule, it takes time before you ultimately diagnose it. So it gives the illusion of being a risk predictor, meaning something in the future. And I think this is really getting to be more and more of a challenge. But I think the definitions that Rowena put up are really important for us to consider. I can tell you, I got a phone call recently from the American Cancer Society saying that they're getting this challenge now with blood tests, that the companies building these markers are claiming that they have risk predictors, and how should they describe them? Is it really a risk or is it a diagnostic test? And there's just so many things that are important about this, because if it's diagnostic and you have a score, you got to act immediately. Whereas if you say it's a risk, you're kind of saying, hey, maybe you can modify some of your risks, and maybe do so. You don't have to act immediately. It's something in the future. Whereas diagnostic, it's there. This nodule gets a high score. Even though we use terms like the nodule is high risk, technically that's not a good description. It's not a risk of being malignant. Is it malignant right now? So that to me is it's a really interesting problem. And I just say that I saw an example of this in this meeting, and I don't mean it in a negative sense, because you saw in one of the talks by our friends at Median Technology. They gave wonderful examples of ROC curves, and they compared their tool, which is a diagnostic probability tool, and showed that it performed in 1 year better than Sybil did. Now, Sybil claims that it's a risk predictor, and that's how they bill themselves. But in fact, if it's giving malignancy probabilities within 1 year, it's not a risk predictor. It's a diagnostic characterizer. Whether it has future risk associated with it is something else. But when you look at the 1 year, and that's really what it's doing. It's finding nodules, and it's saying, because having emphysema, if I say a person has emphysema, the chance that he's going to have a nodule within a year is not going to be, you're not going to get AUCs of 92%. So all of these, the difference between using AUCs with highly imbalanced data sets versus the calibration of the models, where these models are extremely poorly calibrated, I think so these kind of things can become more and more of a challenge. Matthias, do you want to ask a few questions? I don't want to. take this away.
Yeah, no, I think
More
you
questions.
brought so many questions up that it's almost impossible to do this without any risk. So I think I want to bring up then an example to make it a little bit more concrete. We had a discussion for over a period of 10 years on the issue in the Netherlands, on the issue of pulmonary embolism. So you have the natural course when you diagnose, when you suspect a pulmonary embolism, you have a natural course of the disease, of course, with a certain mortality. Also from the anticoagulants, you have a mortality rate, which is quite high in that time. It was up to 5%. And also from the diagnostic invasive test in that time, that was pulmonary angiography, you would have mortality. Now, the first thing that was brought up, that the mortality rate of, in that time, of invasive pulmonary angiography was estimated far too high, but it was 1%, and that was totally unacceptable. But the mortality rate of the treatment was 5%, and that was very acceptable. So that is, in the mind of a radiologist, totally incomprehensible. So there you see already that the background of what is risk and what is diagnosis in that terminology differs already per specialism. Now then, what you could do in that time, and that's what we did, we developed diagnostic algorithms, and then per diagnostic algorithm, we defined the mortality rate. So you could, just by making the division of the probabilities of the disease in the diagnostic algorithm, you could calculate at the end what the mortality outcome would be, also in terms of costs, divided over the different outcomes of the population. Now, from this figure, that was also the mixture, and that is what you are mentioning. What they are doing is, if you have a diagnosis over 1 year, you would like to call it still diagnostic test, but where is the perspective? 2 years, 3 years, 4 years, and then it gradually comes to risk. So I think it's also a matter of terminology, and in this example, it also shows that the background of the specialty is really defining where you accept risk and where you do not accept the risk, and that it involves also the treatment at the end. And only at the moment that we could define a diagnostic algorithm that would come at the end to the lowest mortality, that was convincing for all specialties that you could even implement pulmonary angiography. So the discussion of this whole thing to the end is very important. That's what you want to trigger here. And it's so complex that it will take time for every one of us, and also from the different backgrounds, before you can really come to a sharp conclusion here. And I think what you bring up is very important, is the terminology issue. So I would like to go through everyone. You've heard the whole discussion. How would you define risk now, with all the information you have now? And how would you define probability? And how would you define, at the end, the whole concept of what we discussed so far? So I would like to start with you at the end.
How would I define risk and how would I define probability?
Yeah,
So-
or diagnosis.
Right, so to me, risk is about predicting the future. Probability is about answering a present question. So what is the probability that I have lung cancer now is the diagnostic concern. What is the risk of me getting lung cancer is a predictive future concern. And like Ella said, this could be conflated into one. I mean, it's hard to separate the two. And sometimes you think you're talking about predicting, but you're really talking about diagnosing. The farther out in the future, obviously, you're talking more risk, and the more immediate the concern, you're talking probability, in my mind.
So I agree with everything you just said. I think if I think strictly on the lens of a diagnostic radiologist, you know, a nodule is both a diagnostic finding, right? We look at images, we find abnormalities. It's a diagnostic finding. A nodule, even if it's not cancer, places a patient at higher risk of having lung cancer in the future compared to a patient who has no nodules at all. So there is, it is hard to completely separate diagnosis and risk prediction at the same time when looking at imaging. If you think about the diagnostic history of how you get to screening in radiology versus, say, a blood test, which is something we don't routinely do to people, and now you have these MSEDs that are, you know, drawing bloods, predicting cancer, you don't necessarily know what body part. So imaging is in this weird space of diagnosis, screening, and cancer probability, and then how you explain that to a patient when it's a blur to us, I think is even more difficult. Doctor, do I have cancer? Well, I don't think you have cancer now, but it could be cancer, but I can't tell you the answer because it's so small, it hasn't grown, we're going to manage it. But I haven't answered the patient's question. Do I have cancer or not? Do they have cancer or not? So I think there's this blur on the diagnostic to probability spectrum of how we look at images and how we explain them.
But that really interferes also what we discussed yesterday, that's the actionability. So how do we handle this? So are we only talking about actionability with the patient and keep this difficult discussion for ourselves? Or are we going to be completely transparent and communicate that we do not know exactly what the risk is and the probability is and let the patient make the decision? So what do we do? That's for you.
So in my mind, a risk should be modifiable. A diagnosis is not modifiable. That's a good point. Right? And so either you might have a probability of a diagnosis, but you can't modify that probability.
Yeah, the only thing I have to add is I think the time horizon makes a difference here, right? So if you're looking further out, just like weather reports, you know, you have less certainty, right? So that's a risk prediction model. But if it starts to converge on a causality time frame, like is in, you know, you see a cancer that's highly speculated in the lungs, that starts to look like a diagnosis.
I think risk is something that you can predict in 1 or more than 20 years, something like that. It's future stuff. And for the diagnosis, I think they are both actionable. Even you diagnose something, you can actionable in the future, unless he is not dead.
Well, on the definition, I think I agree with everything that has been said before. And when I go back to your question, I'm a big fan of shared decision making, so giving the patient a voice in my outpatient clinic room. But I think we should guide them to some extent. So I can tell them you have a nodule, and there is a 2.3% risk of malignancy in the next 5 years, for instance. When we talk, this is like on the crossroad between risk and diagnosis, because I know that the probability of it being cancer is actually very low. But of course, I cannot promise this patient that it never develops into a cancer or another. But the patient cannot, I believe that the patient can't make a decision there to have a biopsy or not, because some patients will just, go out of their mind. There is something, it might be cancer. The doctor said it might be cancer. This very low probability is just forgotten already. So I think we have the job to guide them in these decisions and use the probability to make, still you can make shared-based decisions in some indeterminate cases, but especially for the low cases, we should not ask for their opinion if they want a biopsy there. I think that's also part of our job. to prevent the risk of unnecessary side effects, because that's also a risk.
All the other things come in.
I know that I'm on a good topic because I'm getting texts from people questioning some of this, so I think that's a good. Let me just give you another example. Person has a non-solid nodule, right? It doesn't get diagnosed for 6 years, 10 years sometimes, because we're willing to watch it. Now, does that mean have anything to do with risk? It was, when we first saw it, it was cancer. And yet, well,
Could have been pre-malignant and it became cancer, right? Solid component appears.
no. I mean, you have a 1 or 2 centimeter non-solid nodule that we're leaving alone because it's growing slowly. Yeah, or even a part solid, whatever. These things, if you, virtually all the time you biopsy these, they don't transform. I mean, some of the small ones, maybe they do, but, in general, these are malignant. It's just the idea that you're going to predict time when it's going to get diagnosed. Those are kind of clinical decisions. They're not something that AI can predict. True. I mean, and when you look back at them and you see this thing that, I have cases I followed for 14 years, 15 years, and, you just watched it grow a little bit every year. I know that if I had taken it out or biopsied it the year before or the year before, it would have been the same diagnosis as it is today. So it gives this illusion of risk that it, and it's not. And so if a tool, what I'm driving at is a tool can't predict when it's going to get diagnosed. It's not able to do that. That's a clinical decision. It's a similar thing with small lung nodules. You have a small cancer. A lot of times there's no workup on it, but that doesn't mean it wasn't cancer then. But it gives an illusion, if you use a model, that it is a cancer, that you're doing risk prediction, because it wound up getting diagnosed years in the future when it grew to a size that was large enough to do something with it. So it gives the illusion of risk. It's not that the nodule was at high risk of being cancer, it's that you didn't diagnose it at that moment.
So I think what you're getting at, if I'm trying to read the tea leaves here, is that what is cancer, right? We know that many people have little tiny cancers in their body that their body is controlling, right? One of the most striking examples to me was a patient whose lung nodule we had followed for 6 years, sub-centimeter solid, didn't change 1 iota. They got their lung transplant, they got immunosuppressed, and within 3 months they had metastatic lung cancer. So your body is controlling little tiny cancers that you're developing all the time, atypical cells, clusters of cells. And so I think the question is, what is an actionable cancer? Something that is likely to impact the host, the human being who has it, versus a cancer under the microscope, hence the pure GGOs, right? We assume that the majority of the GGOs are cancer. Some of the guidelines, once you develop a solid component, then it becomes actionable or a growing solid component, because that's at least a sign to us that we believe it's becoming more aggressive. And sometimes we may miss the mark even with that type of distinguishment. So what are you willing to live with versus what can't you live with? And we can assign medical probabilities to it, but we can't really get into the heads of an individual patient. A patient who's had several family members, for example, who've had a poor outcome from lung cancer. To that patient, that nodule, even though we're saying it's a pure GGO, it's a cancer, it's not likely to do anything to you, we're going to watch it. That cancer feels very different to a family history of never having had lung cancer. So I think there's more than just the imaging features and the probability that it's going to grow and impact the human that it has it over time. I think it's more complicated.
Well, but to me, it's that.
Can I add to that? I think we're not discussing the fact that tumors are very heterogeneous. And in clinical practice, you do see radical changes in the behavior, the clinical behavior of a particular lesion. And maybe if we focus just on screening, it's true that we tend to have this bias that we see nodules over time and that they don't appear to change very much. But in clinical practice, you oftentimes do see these radical changes, multiple clones in a particular lesion, that one clone takes over because of a new mutation, and then all of a sudden, the tumor takes off, and tumors that change from squamous cell to small cell differentiation and things like that. And so in the screening world, we tend to see more stability in these lesions because we have that luxury of detecting them early. But in clinical practice, in advanced tumors and larger tumors, we tend to see this heterogeneity. And so they're different animals, so to speak.
If you think this is a problem in imaging, it's a bigger problem with these blood tests because they really are. See, I don't think it's so much, when I see a 3-millimeter nodule and I look at it, and then you look back and, now it's 1 centimeter, you look the year before, it's 8 millimeters. And I know it was cancer back then, But with the blood tests, they are really getting into this domain where maybe it isn't really cancer. There's some genetic instability, there are some mutations, but it's not quite cancer, it may be a risk of cancer. There it gets really subtle. With imaging, I think we're a little bit more on target. I'll ask one more question to the panel that's related is, what do you think of the idea of doing blood tests when you have a patient with a nodule? Does that help clarify? Do you think we're at that point? If somebody comes in with an 8-millimeter or a 1 centimeter nodule, are you ready to do a blood test or a nasal swab and say, hey, now I think it's malignant? Or are you still saying, got to get a 3-month or a 6-month follow-up or whatever? Do those blood tests help you at all?
Well,
What's your feeling on this?
I think we know for some extent, especially in when the patient has lung cancer, so when the nodule is malignant, that for instance the ctDNA can help us also find it also in the diagnostic process. So we think we're looking at a stage 1 lung cancer, but then we find ctDNA preoperatively, post-operatively, and then I think we should think by ourselves: did we miss something? Was it really a stage 1, or is there some occult lymph node still present, or is there already like a small metastasis present that we missed? So, but that's in the case where you're already in the diagnostic process for lung cancer. In my view, it's too early to use it now for very tiny lung nodules because we need, well, much better performance of these systems and much better consistency of these tests to proven external validation, everything.
It was a little bit of a trick question because, just for fun, because did you use the blood test diagnostically? You found ctDNA of tumors, or did you use the blood test to say he's at a higher risk than, he's just in general, his risk is higher and therefore it elevates the probability that that nodule, because, when you use something like the Brock model, it uses things that are true risk markers, age, that's a risk marker. It incorporates that into its diagnostic probability. So when we use a blood test, are we using it for diagnostic purposes? You're looking for tumor DNA, or are you using it to say, hey, this person's at a higher risk in general, and therefore we incorporate that into the probability. But anyway, let's just hear what the others do. Do you use the blood tests? Are you using blood tests now to help you with
So no,
with
I don't think
nodules?
anybody is using routinely blood tests. Now there's a number of tests that are available, so that's it's a long answer to. You have to have an idea of what you're asking of the blood test. So are you ruling in disease? Are you ruling out disease, for example? And what are you doing with, where are you placing the biomarker? So are you placing it to select individuals at risk? Are you placing it to characterize nodules in terms of malignancy? And this was, for example, with the autoantibody test that was published in the ERJ. So it's a big study in Scotland. And the test was placed before screening. So if you had a positive test, you went for every 6 months screening for 2 years. If you had a negative test, you went for routine follow-up. And the big criticism of that study was all that you demonstrated is that the people who underwent CT screening had a benefit. And because you put the blood test before the CT screening and you couldn't really judge what the effect of the biomarker was because you confuse the issue, you bias the issue with the fact that those individuals who had a positive test got screened and those who didn't get screened. And so in reality, you just proved that screening works with CT, not with a blood-based biomarker.
Now,
so a very complicated issue in terms of validation.
We are going to be having a whole other session later on blood-based biomarkers, and we have some real experts here in that topic. So I wanted this to at least lead into that a little bit.